Today we are going to talk about what is erythema multiforme. Erythema multiforme is an immune-mediated, typically self-limiting mucocutaneous condition characterized by target lesions. Significant mucosal involvement distinguishes erythema multiforme major from multiform minor. Episode can be isolated, recurrence, or persistence. In most cases, erythema multiforme is precipitated by herpes simplex virus (HSV) infections. Alternative triggers include other infections, medication, and vaccinations. Classic target lesions present as concentric rings of color variations which develop symmetrically in an equal distributions, with or without involvement of mucous membrane. Erythema multiforme is a distinct entity from Stevens-Johnson syndrome (SJS) and toxic epidermal necrosis (TEN). Medication which may trigger erythema multiforme include: first, antibiotic includes erythromycin, nitrofurantoins, penicillins; second, anti-epileptics; third, non-steroidal anti-inflammatory drugs; fourth, vaccinations, most common cause in infants. Other conditions associated with erythema multiforme, usually in persistent disease, include inflammatory bowel disease, hepatitis C, leukemia, lymphoma, and fourth, solid organ cancer malignancy. In many cases, the inciting factor remain unknown. Most research on the mechanism of disease has focused on the herb-associated presentations. The herb virus is phagocytosed by mononuclear cells, which express cutaneous lymphocyte antigens, a skin-homing receptor, and gut viral DNA is then transferred to the epidermis and into keratinocytes. Within the keratinocyte layer, expression of viral DNA fragment includes a cell-mediated immune response, including production of interferon gamma, which upregulates the inflammatory process. Cutaneous feature: cutaneous lesions develop at the peripheries before spreading centrally. Distribution is usually symmetrical with a preference for extensor surface, may be painful, pruritic, or swollen. Early lesions present as loud erythematous papules, which later develop into target lesions. Target lesions consist of three concentric rings of color variations, a central dusky area of epidermal necrosis, surrounded by brighter erythematous areas, with a peripheral erythematous margins. How is erythema multiforme diagnosed? Diagnosis is often made based on history and clinical examinations. Where there is doubt about the diagnosis, consider complete blood examinations. Second, liver function test, the ESR. Fourth, serological testings for infectious cause. Fifth, chest X-ray. Skin biopsy with histopathology and direct immunofluorescence can be non-specific, but help to distinguish erythema multiforme from other more serious differentials, such as autoimmune blistering disease, upper dermal edema, and individual epidermal keratinocyte necrosis are suggestive pathological features. All Pantene with recurrent erythema multiforme should be tested for herpes simplex virus, including sampling of skin mucosal lesions in recurrent or persistent erythema multiforme. Without clear precipitants, consider workup for solid organ or hematological malignancy. What is the treatment of erythema multiforme? Treatment is often not needed as episodes are typically self-limiting with no ongoing complications. However, ocular involvement should away from ophthalmology is referral given the risk for more serious sequelae. Treatment for symptomatic mild case is oral antihistamines or topical steroids. Pains for mild mucosal involvements, oral wash containing antiseptics. Other treatments are depend on cost.